Hello, everybody. Welcome to a new ATS webinar hosted by the Thoracic Oncology Assembly Early Career Professional Working Group. Today's webinar is about the impact of climate change induced severe weather event on lung cancer care delivery and outcomes. I am Eman Metwally, a pulmonary and critical care physician by training and currently a postdoctoral research fellow at the University of North Carolina at Chapel Hill. I'm delighted today to co-moderate the webinar with Dr. Soumya Niranjan. Soumya.
Hello, everyone. Thank you so much for joining. I'm Soumya Niranjan. I'm from University of Alabama at Birmingham. I'm a medical sociologist by training, and I'm looking forward to a great conversation with all of you all. I want to introduce our esteemed panelists. We will be starting with Dr. Jennifer Lund. Dr. Jennifer Lund is a professor of epidemiology at the University of North Carolina at Chapel Hill and the Director of Data Strategy and Education for the Cancer Information and Population Health Resource within the Lineberger Comprehensive Cancer Center. She conducts pharmacoepidemiologic and health services research with applications to cancer, aging, and the environment. Funded by the National Institute on Aging, the National Cancer Institute, the US Food and Drug Administration, and the Patient-Centered Outcomes Research Institute, her research program aims to generate robust evidence on the utilization and effects of medical interventions that inform decisions made by patients, their caregivers, healthcare providers, and policymakers. Together with her team of trainees and collaborators, Dr. Lund leverages clinical trials, disease registries, administrative databases, electronic health records, climate hazard data, and their linkages, along with advanced epidemiologic methods to study the delivery of high-quality medical care, the effectiveness and safety of alternative treatment strategies, and the role of climate-driven extreme weather events on treatment access, adherence, and outcomes, resulting in more than 200 peer-reviewed publications. Dr. Lund serves as an associate editor or editorial board member for several scientific journals. She is a fellow of the International Society for Pharmacoepidemiology and co-chairs the Environmental Pharmacoepidemiology Special Interest Group within this international society. Our next panelist is Dr. Leticia Nogueira. Dr. Leticia Nogueira is a scientific director of health services research at the American Cancer Society. Her research focuses on cancer disparities that can be addressed through policy changes, especially those related to climate change and structural racism. She is also an adjunct professor at Emory University's Rollins School of Public Health. She was selected as one of the inaugural NIH Climate Change and Health Scholars in 2023 and was inducted into the Hall of Honors at the University of Texas at Austin in 2018. Earlier in her career, she received the Fellows Award for Research Excellence from the National Institutes of Health and the Women in Cancer Research Award from the American Association for Cancer Research. Dr. Nogueira earned her PhD in molecular biology from the University of Texas at Austin and her MPH in quantitative methods from the Harvard School of Public Health. Last but not least, Dr. George Anesi is an assistant professor of medicine at the University of Pennsylvania Perelman School of Medicine, where he has an NIH-funded clinical epidemiology and health services research program focused on hospital preparedness and capacity strain. He serves as director of the Medical Critical Care Bioresponse Program at Penn and as chair of the ATS section on terrorism and inhalation disasters. Thank you so much for the panelists, and we are good to go. Eman?
Yeah. So I'd like to remind everyone that this is a live webinar that will be recorded and uploaded to the ATS website. The views expressed in this webinar are those of the speakers alone and not necessarily endorsed by the ATS. And a brief introduction. So human misuse of Earth resources has warmed the atmosphere, ocean, and land, and changed the climate faster now than at any point of modern history, adversely impacting people's life and health. Although severe weather events do not Although severe weather events do not discriminate which community they may strike, older adults and patients with chronic conditions are most affected. Patients with cancer are particularly vulnerable because of their needs for continuous cancer care during their journey for cancer diagnosis, treatment, and survivorship. Lung cancer is of high priority in this context because it is the deadliest cancer, the cancer most often linked to hazards of air pollution. Further, patients with lung cancer are often diagnosed at an older age when comorbidities and frailty are common, making them more vulnerable to physical, mental, and emotional stress of severe weather events. In a study by Dr. Nogueira and colleagues that was published in JAMA 2019, they looked into the association between declared hurricane disasters and overall 5-year survival among patients with locally advanced non-small cell lung cancer. They observed that comparing exposed to unexposed patients, those who were exposed to hurricane disaster during receipt of radiotherapy treatment had longer duration of treatment and poorer survival. Further, among patients exposed to hurricane disaster during treatment, there was a positive association between mortality risk and length of disaster declaration in days. Here in the graph, you can see on the y-axis the mortality risk, and on the x-axis the length of disaster declaration in days. The solid line is for the main estimate, and the dotted line is for the upper and lower 95% confidence limit. The association showed that the relative risk of death was 1.27 among those who had around 30 days disaster length. The association rendered non-significant after 30 days. However, most of the events that were studied in this study was less than 30 days. And then we can delve into the discussion. Let me stop sharing here. Yeah. And maybe I can ask the panelists, regarding the health impact of severe weather events, physical injuries, drowning, and fatalities are well-known health impacts, but little is known about the impact of severe weather event on healthcare delivery. How do severe weather events affect healthcare delivery for patients with lung cancer? And anyone can start.
I'm happy to start things off. So first of all, thanks so much for the opportunity to be here. Thanks for the invitation. Thanks for the host and the co-panelists. I was really looking forward to this discussion. So and just maybe a little bit of context. I appreciate the introduction, and I'll just note I'm not a pulmonologist, but I'm not a thoracic oncologist. I come at this from clinical epidemiology and health services researcher perspective on kind of all hazards preparedness. And while I think there's a lot that's unique about climate-related severe weather events and the interaction of that with lung cancer and kind of adjacent trajectories of clinical disease, I think there's a lot that we can bring from the kind of the all hazards preparedness approach. And I certainly hope so, because we'd like our work to be applicable and for different insults. So maybe I start there and just say that, I look at a severe weather event and I first start with our really high level framework about how we look at healthcare delivery and interruptions in healthcare delivery during situations like that. And I think about, what makes a surge event. That's a term we use a lot in our niche. And it's when there's some unexpected increase in demand for care. That's the kind of the traditional definition, more patients. But, we've certainly tried to add nuance to that over time and suggest that, even if it's a smaller number of patients, but they have higher acuity than a treating facility might be used to, if they have more unique care demands or care needs, specialized personnel that need specialized equipment, that's different. And a smaller number of patients can still contribute a similar high amount of strain in those scenarios. Or if there's a concomitant infrastructure damage or reduction, and certainly that's particularly relevant for the scenario of severe weather events. So if the same number of patients are trying to receive care and you have interruptions in supply chains, interruptions in how you power your facility and so forth, that's a surge event, even if the demand is the same. And usually in these types of events, they're going to come in at the same time. That is to say, increased demand and infrastructure interruption. So I take that as a high level look, and then I also think about the preparedness literature kind of canonically talks about the S's of preparedness, so like space, staff, stuff, and systems. And space is kind of where we would take care of patients, so that the physical spaces. Staff is the appropriately trained personnel to deliver that care, both at the bedside and in terms of coordination. Stuff is anything kind of tangible, so medicines, mechanical ventilators, and then systems is this recognition that there's a huge amount of coordination that goes into delivering care. So if you just give a new hospital 10 more ventilators and another intensivist, you're not going to get the same degree of care delivery as you are of the hospital that's used to having 20 mechanically ventilated patients. So it doesn't magically come just with the presence of the resources. So those are my introductory remarks, which is to say that I approach this looking at it first through kind of an all hazards approach, and then I start to think about the nuance of cancer care. And I'll add one more thing before I pause, because I don't want to monopolize time on the first question. But to say that we say lung cancer patients with lung cancer, but I guess I would hope that we would address it across the full spectrum of cancer-related care. That is to say, active cancer care, post-treatment surveillance for recurrence and ongoing issues, active diagnostic approaches to an identified pulmonary nodule, for example, and age-appropriate cancer screening. I think that we would want to address all of those in a comprehensive approach to this. So I'm going to pause there for my initial remarks, but I appreciate the opportunity to participate. Thanks.
Yeah, wonderful. Leticia?
Yeah, so I'll build a little bit. Thank you for already you did a beautiful job summarizing our research, but I'll add a little bit about the rationale that drove us to ask that hypothesis, right? And I'm again so excited to be here, and thank you again for the invitation. So I was coming at this question from a cancer perspective. I've done cancer research for most of my life. And I was in Texas when Hurricane Harvey hit. So it was kind of a trial by fire on how severe weather events can impact cancer care. And building on everything that Dr. Anesi already said, if you add the climate change component to it, right? So you have this, the Centers for Medicare and Medicaid Services already requires that any facility that gets payments from Medicare and Medicaid need to have an emergency preparedness plan that follows the all hazards approach. There needs to be a communication plan and a patient transfer and a backup power source. The problem is that with climate change, these events, these extreme weather events are behaving differently, right? So Harvey was an example where because the air is warmer, then there is more water for these storms. And so it was the flooding and that was the biggest problem with Harvey. And all the hospitals we were working with had all their checklists, but nobody was prepared for what Harvey did. Then Maria hit a few months later and did something very similar. And recently, Hurricane Helene, unfortunately, hitting your state. Again, nobody thought that amount of rain would reach that far inland, right? And you can see how the consequences of extreme weather event that behaves differently can be much more impactful. And for that study and focusing a little bit on the cancer patient perspective when it comes to these severe weather events, exactly what Dr. Anesi was saying, there is this infrastructure component, right? So you might have an emergency power source, but it might not be destined for radiation oncology, for example, because that might not be considered a priority. Your hospital might not have suffered any infrastructural damage, but maybe the transportation routes have, and the patient cannot get there. Or the specialized team that's needed to deliver radiation therapy in these studies, for example, cannot get to the hospital, then you cannot provide treatment. And so we picked a cancer that's very aggressive, for which we knew that any small break in treatment
would make a difference, would give the tumor a light up. So radiation therapy is usually given every single day. So if a disaster hits and there is an interruption, and for such an aggressive tumor, a break of 2 days can make a difference. So that's why we selected that study at first, because it really did capture this higher vulnerability or higher risk for the impact of these events that comes with a lung cancer diagnosis.
Yeah, thank you. Jenny?
I think, I don't have a ton to add other than also to say thank you for the invitation. It's really a delight to be here, and for all the participants who are in the audience. This is really great that you're here and interested in this topic as well. Maybe the one kind of final point on this question that I could raise would be, we've talked about kind of the infrastructural issues, some of those kind of around the healthcare facility issues with, the roads and transportation networks. I guess one additional consideration is that for individuals and families and communities that are hit by these disasters, there may also be kind of a personal deprioritization of some of the healthcare needs that they have, because there are more immediate needs that need to be addressed, like housing, food, water. And so I think it always, in the context of when we speak to people who have lived and survived through these disasters, I think the priorities of what you think is most important really shift, particularly in the short term, but potentially also in the long term if you are struggling with housing insecurity and trying to figure out where you're going to stay. So that may be the other way that ultimately that may impact delivery and kind of outcomes of patients with lung cancer.
That's very helpful. That's a really good point you raised. I was kind of moving away from lung cancer specifically and looking at some of the comorbidities that are usually associated with lung cancer and other cancers, to Dr. Anesi's point. So how does that look like when it comes to SWEs and the management of comorbidities? That suggests then that not all the care is in one place, and how do we kind of think about it? How do we go about it?
It's a very good question, and it builds on what Dr. Lund was talking about, of this shift in prioritization, right? So you might have had being able to manage your diabetes for decades, and you know exactly what to do, and you keep your insulin refrigerated, and you have the times of the day when you take care of it, and you got this. And then Hurricane Maria hits, for example, and that turns everybody's life upside down. And then there's this deprioritization of chronic disease management. And in fact, there's a lot of research showing that the excess deaths in the aftermath of Hurricane Maria up to 1 year were mostly due to these interruptions in access to healthcare or a deprioritization of management of chronic health conditions. So you really see with cancer, you have these comorbidities, right, that come. It's a very high percentage of cancer patients who have a comorbidity, some other chronic health condition that needs management. And on top of that, the side effects of the treatment can also have an impact. So some chemotherapy drugs can make regulating your body temperature harder. And so if you have either extreme heat, as we are having more and more often, everybody's tired of hearing that in the news, or extreme cold, which is also associated with some climate events, such as what happened in Texas in February of 2021. Both of those can also be impactful when you're trying to manage the diagnosis, the comorbidities, and the side effects of the treatment.
Anyone else like to add in? Yeah, Dr. Lund.
Yeah, maybe just one thing, and maybe I can pass it to Dr. Anesi after, because, as a pharmacoepidemiologist, I'm really interested in kind of patterns of medication use and how people access medications. And in the context of extreme weather events, pharmacies, the way that generally outpatient pharmacies work in the US is that they are separate from the healthcare system. Many of them are commercially owned and part of large chains. And so I think in general, they don't tend to be as integrated into some of these emergency disaster preparedness kind of networks and plans. They have their own emergency preparedness plans, but it's not really integrated with usually the rest of the healthcare system. So I always think about how the closure of pharmacies in like before and during and after these kinds of events really can impact individuals' access to their medications to manage chronic diseases. And in some communities, those pharmacies, when they get hit by these kinds of disasters, actually don't reopen again. And then it leaves certain communities without access to medications where people have to go further to get their medications generally. So I don't know if Dr. Anesi has more to say kind of on that integration piece with more of the other healthcare system actors.
Yeah, no, it's a great point, and it certainly extends like well beyond this particular niche question that there's a big separation, certainly in American healthcare anyway, between kind of acute care, longitudinal ambulatory care, and pharmacy for many things. And that definitely presents a lot of vulnerability where you kind of don't really know what's happening across that kind of gulf. And so, yeah, you can certainly end up with scenarios where you have big interruptions, shortages, or semi-permanent or permanent closures, and end up with kind of pharmacy deserts, and so to speak. The other thing that came to mind in starting with Dr. Nogueira's comments were this prioritization phenomenon, and we also kind of call this, not totally the same, but very similar, this bystander phenomenon, where during a disaster event, there's this shunting of attention to kind of what the most perceived to be acute issue is, which is often tied to the etiology of the event. So for a weather-related event, it's often the trauma of people who were injured physically, injured by floodwaters and by trees and by things like that. And during a respiratory viral event, it's people who are infected by that particular virus that's driving that surge. And there's everyone else, we call them bystanders, but it's really, those are actually more numerous, typically people who are not impacted by that direct insult, but have kind of the secondary effects and need all of their normal acute longitudinal care during and after said event. And then I think there's almost a second layer of this, which is, if we're talking about our lung cancer patients who certainly some of them may have been caught up by the direct insult, but we're talking more about their kind of ongoing care. And they, within themselves, will have an added prioritization of, I've got my cancer care, and then I've got all these chronic things that maybe I can not worry about them for a little bit. And I think physicians, unfortunately, probably have a similar knee-jerk response, which is, okay, we can't worry about like health maintenance right now. We need to just figure out like the big things. But we see how that very quickly catches up to individuals and catches up to us as a healthcare delivery system. I mostly take care of patients in the ICU, and I've used the same phrasing in so many conversations over the years, which is that, the body's really interconnected. So it's really hard to manage issue A if issues B, C, and D are kind of flaring up, and vice versa. And so, it's going to be much harder to kind of, continue good cancer-directed therapy if, your diabetes and heart failure and COPD is really acting up, and vice versa. And so I think that there's this prioritization, this kind of bystander effect that occurs at multiple layers. And it's natural to prioritize. One, if you're going to prioritize, we got to get it as optimal as we can. That is to say, really make the prioritization make sense. But also, we got to make sure that not being on that top of the list doesn't mean true neglect. It means, there's a plan to resurrect, or there's a very short time window, or it's not full, or something that doesn't allow those to become bigger issues. Very complicated.
Yeah, certainly there are many challenges facing patients with lung cancer, either related to the cancer itself or to underlying comorbidities. I believe that these problems will maybe escalate when the patients are displaced from their homes and communities. Usually when severe weather events are anticipated, many areas had evacuation orders issued. And I'd like to ask, what are the primary barriers to continuity of cancer care for displaced patients, and how do these barriers influence treatment adherence and patient outcomes overall? And yeah, any of the panelists can take it.
I can maybe get it started. So I think it's much bigger than treatment adherence, right? It is, for example, we have a study with lung cancer patients who are recovering from lung surgery, which is not an easy surgery to recover from, right? There is a lot of complications, cognitive due to the medicines that you're taking, mobility, right? Because you're in pain. And so in this study, we evaluated impact to wildfires near the house after the patient is discharged from the hospital following lung cancer surgery. And we really do see that it's so much more than just breathing in the smoke of the wildfire or not being able to go see your oncologist because there's an evacuation order. There is this, is my house going to burn down? Right? How do I keep up with the evacuation orders? Because especially for wildfires, they change very quickly. There's the water contamination, the soil contamination, even after you come back, if your house was safe. And of course, that there is the mental health impact that such a traumatic event can have. And so I think that when it comes to care, we all tend to focus on the care that is closer to our daily activities, right? So we think about adherence to medication or to medical advice, when in reality, there's so many other things that are piling up during these events that I find it sometimes useful to take a step back and look at, the patient, the family, the community, their interaction with the healthcare services, but also their socioeconomic situation and their stress level. So I think that, as Dr. Anesi was saying, there's never an isolated component of your health, right? Or your interaction with the healthcare system. And the more we take time to take a step back and look at this patient healthcare service community as a whole, I think that it will be much easier to identify solutions that are relevant beyond wildfire, beyond lung cancer, right? As you're saying, our hazards and maybe every step, the lessons that we learned by looking at the bigger picture can be useful for many other situations.
Yeah.
Yeah, there were two things that popped into my mind when you mentioned this kind of displacement from home and community, and one is that I think that cancer care in particular, there's probably some other, or there's probably many other diagnoses for which this is also true, but it certainly resonates with me significantly with cancer-related care, that your kind of home institution or clinic or wherever you receive your kind of coordinated cancer care is very much your cancer care home, and that when you happen to show up to a hospital that is not in that healthcare system, it is like you parachuted onto Mars. I mean, I practice in Philadelphia. I'm at Penn, and there are multiple big healthcare systems in our city that have large comprehensive thoracic oncology programs. And if a patient who's got an active chemo plan and an imaging schedule, but it's at Temple, and they happen to show up to the Penn ED because they were closer there when they got sick, and that's where the ambulance took them, we're kind of like, what do we do? I don't want to touch anything too much. Like, we're going to fix your acute issues. We're going to take care of your breathing, but we don't, like, I don't, we're going to, Monday morning, maybe we'll call your oncologist. And so there's really this home effect of your home institution effect for comprehensive cancer care that I think is, and all of a sudden that sets your clock back, right? When you end up, because your home hospital is closed or because you had to evacuate and you end up at a different place, it really kind of disrupts that that time frame, that communication, everything. So I just note that as a clinical anecdote. And then the second is I think if you picked someone up from their home and brought them to a family member's home or brought them to a hotel or brought them to a FEMA shelter, and you brought every single med they need and every single piece of equipment that they have at home, they would not have the same care. There's a rhythm of your home space that people develop, a comfort with it, and the exact same resources, but in a different place, is not immediately the same. And I don't know the best way to quantify that, but the move itself is a hit to that rhythm. And so I think that's an added hard to measure element of that kind of evacuation piece of it.
Yeah, certainly the emotional stress of the hurricane disaster itself and then evacuation as well is a big issue for everyone, especially for vulnerable patients like those with cancer.
Dr. Lund, do you want to add anything additional to what we were discussing?
No, I think that was an excellent discussion. I don't think I have anything to add.
So I guess then the next part of it is also moving a little away from displacement into kind of looking specifically around flooding and looking to understand, do you find that from your research and your daily practice that there are certain patients with certain clinical or sociodemographic factors that for whom there is an increased vulnerability when it comes to flooding related health outcomes? And again, you've moved a little bit from the fires to some specifically around flooding, but yeah, I had a question around that.
Should I go first again? I feel like I'm doing this every time. So one thing that we noticed with flooding is that infections are very common when you get in contact with contaminated water, right? And especially for people who are receiving cancer treatment, that chemotherapy, for example, can make your immune system weaker, right? And so when you get in contact with contaminated water, that increases your risk of infections, which can be very bad, spell out very bad news if you already have an ongoing cancer treatment. So this is as Dr. Anesi was saying, the more short-term impact that we see. And then for longer term, even as the flood waters go away and you need, to come back and clean the house, there's, a process. There are recommendations for how to do it, but especially people who either have a weaker immune system or respiratory conditions, there is the mold problem that comes with flooding events that can show up months later and go undetected for a while. And that has been a concern for cancer patients as well.
Maybe just to add on in a slightly different way, I think kind of more at a community level, I think one of the contemporary trends that we're seeing is that the areas that, are now kind of in differential floodplains are communities that are historically marginalized. And what we've seen just recently over the past year or so is even like home insurance, the companies that have provided home insurance in those areas have started to move out and say, we're not going to actually cover any, homeowners in these areas. And so I think when you're thinking about vulnerable populations, it's particularly those who maybe live in a place where they are very likely to be flooded, where they can't be insured or they can't rebuild up to kind of avoid the flood, their home being flooded. I think that's another kind of community level piece that increases vulnerability.
Yeah, and I think we can move on to another point related actually to the healthcare providers' challenges during and after severe weather event. So really taking care of patients who suffer from cancer and also battling additional stress induced by severe weather event can be challenging for healthcare providers, either physicians, nurses, social workers. What are the major logistical, infrastructural, and patient communication challenges that healthcare providers face in delivering cancer care during and after severe weather events?
This is a big question. This encompasses a huge amount of, I think, what we're trying to get to. I think it comes back to the prioritization question, and I think that it's a recognition that you can't do all the things you want to do when there's a crisis event, and you're forced in some sense to prioritize or to ration, whatever word you want to use, scarce resource allocation. But I think that we should probably take a more data-driven approach to that and really understand what are the highest leverage things that we might be doing for patients in different scenarios, both acutely and from a health maintenance standpoint, and to let data a bit drive, the how we take a rational approach to that rather than kind of knee jerk or what sounds most intense or what, and so that's one thing. And I think, any of these events give us an opportunity to study that. And there's other opportunities to study it, but I think it probably should be, taken with a more formal approach. Whenever we're talking about what we might dial back or ration or stop or pause during or after one of these events, I think we have to think very hard about what the threshold is to do that. What would get us to that point? I mean, I remember other colleagues who I don't think are at American Cancer Society, but worked with them on age-appropriate cancer screening decisions during the COVID pandemic about when to recommend interruptions, and just talk about how heart-wrenching a decision that was to call for a pause on that as part of the COVID response. And so really understanding what should be the thresholds for those kind of pauses, and probably a recognition that every such maneuver should come with more specifics of how much are we pausing. It's all or nothing is usually not the right answer. How much are we pausing, and we've identified a threshold to have that pause or that down regulation, but what is the exact threshold to restart? We really need to know the back end of it. It shouldn't be indefinite at any point. And I think we learned during the pandemic that we extended things a lot longer than we needed to in hindsight, and that was probably just okay. We need to stop it. Maybe that was correct, but without a plan on the back end. So I think that's a big piece of it. And then I think that we should always have a healthy recognition that we try to do a lot, especially in Western medicine, especially in American medicine. We try to do a lot of things, and there's probably a subset that accounts for good outcomes and a lot that doesn't do too much. And when you pause things and outcomes don't change, that's an opportunity to identify things that you probably don't need to be doing. And we should always be reassessing what we do. High value care is important. And so if you pause something and things don't change the way you thought they were going to, that's an important opportunity to reevaluate. And I think we should be open to that, not shy away from it. We could talk forever. I'm going to pause there.
But can I ask a related question here? I think that because you were talking about the pausing, have you found in your practice where you have paused and found and then kind of renegotiated how this needs to keep moving forward, like in your practice? Or
it's a great question. So I think that we certainly identify. Well, I'll give you two buckets, I guess. At least in not specifically related to thoracic oncology, which I don't practice except as an ICU doc that takes care of them when they get very sick. But in critical care medicine, we have plenty of things that we did for 15, 20 years that were based on like a 30-person observational study, and it became kind of lore. And finally, it's kind of disproven, and you kind of are relieved that you're able to relinquish this kind of silly thing that you were doing. And so that's like a broad bucket of examples. There's lots of little things in kind of ICU bedside care that have fallen into that category over the years. The other thing I'll just mention is that anyone who works in an ICU, I think noticed this during the COVID pandemic, which is that in late March 2020, at least in Philadelphia, that was the timing for us. Our hospital really emptied out as lots of elective things were canceled, right? We were waiting for this COVID surge, which hadn't come yet, did come, but hadn't come yet. But our medical ICU also emptied out. And why on earth would medical critical illness be discretionary? And now some of that actually relates to our conversation today, because probably some of that is we're not giving as much elective chemo, and patients get sick from that. But that was not the full explanation. And so there are other factors at play that we don't understand that modify disease. And it's also very possible that we do things that keep people sicker for longer under certain conditions. And we need to have an open mind to reevaluate those. And I think I don't have specific answers. I think we should get them, but those are anecdotes that come to mind.
Yeah, thank you.
Eman, I didn't mean to interrupt, but I thought it was such an interesting thing, and I thought it'll help us with the rest of it. Yeah, so please go ahead with the other panelists.
Yeah, I'm listening if Jenny and Leticia anything, because I like what George mentioned about let's our approach be data driven. Let's see what are the most challenges reported by healthcare providers that are preventing them from providing high quality care, either for cancer or for other comorbid conditions during these events. So yeah, I'd love to hear Leticia and Jenny input about that.
I mean, I have to say, I'm not a healthcare provider, so it's hard for me. I do not have personal anecdotes about how these kinds of events have impacted care delivery on on any patient-facing side. I think it, COVID probably has taught us a lot about, in part of the question is about healthcare provider burnout. I can imagine in these disasters, people, particularly in the emergency setting, are working nonstop, treating people who are coming in and they're getting transferred. I've, again, anecdotally heard from other hospitals, they ran out of certain kinds of medications, again, because the pharmacies around them had closed. And so there was shortage and, so just that kind of being in that chaotic environment, I think there's lots of lessons probably that can be learned, but it is stressful and chaotic, and burnout seems to be a real outcome, following these kinds of events. So, to the extent that obviously what we've learned about how to care for the people who are caring for patients coming in, I feel like that's a big place where energy should be devoted as well.
Yeah, thank you.
Yeah, I completely agree. I was going to say something similar. Sorry, Dr. Anesi, but you did exactly what I was going to say, where the healthcare professionals think about the patients and the patients only, right? But from a data perspective, healthcare professionals are people too. And so these traumatic events do have an impact on the team, right? And we see this. We saw the exodus from healthcare professionals from Puerto Rico in the aftermath of Hurricane Maria, and then even larger as a nation, right? Just an exodus after the COVID-19 pandemic. And so we got very good at collecting data, especially cancer data. I used to say that cancer is the ambassador of public health because we have best data. And we got very good at collecting that. But are we also paying attention to, as we were saying, right, the family, the community, but especially the healthcare professionals, and when there is a traumatic event, what are strategies that can be implemented to make sure the entire system is working, right? Not just that the patient is being taken care of, but that your team is also being taken care of and can continue to contribute. And I was just going to mention one more thing from a systems perspective, and especially working with cancer, a lot of times we know the disaster is coming, we have more than 3 days in advance for hurricanes, for example, that we know this is coming. And so some of the recommendations, right, create a plan, a disaster plan, an evacuation and shelter in place, have a kit, flashlights, water, have a kit with your medicine. When we get to that point, a lot of times for chemotherapy and some other medications, you will also say you might want to request additional medication because you might be displaced. So you want to have that medication with you. And from a systems perspective, there are a lot of barriers to that, right? Your health insurance might not allow you to. Yes, I see Soumya agreeing. So I'll let maybe you interject because this, you have the individual, you have the healthcare professional, and then you have the healthcare system. And there are barriers for providing quality care during these traumatic events at every single level here.
Interestingly enough, my next question was around how do we integrate this? So I guess I would ask the other panelists to kind of talk about perhaps some specifics where you've seen this integrated better than other places, or at least are emerging new studies that have shown that this is, we don't know what that actual protocol looks like, and has there been places where they've done perhaps a better job than others?
I feel like I can tee this up for Leticia. So I was going to say one of the places or one of the kind of clinical contexts that I think seems to be leading the way in kind of coordinated care around some of these extreme weather events is for individuals who have end-stage renal disease who are getting dialysis regularly. This is a population that is a high touch population. So they go to the same dialysis clinic multiple times a week. And it's life-saving treatment. They need these transfusions, right? So, or dialysis procedures. So basically, from reading the literature, and Leticia has contributed to some of this, so I'm going to let her give all the details. I mean, there have been really good kind of integrated efforts between some of the large dialysis centers and, the local health departments and people who are kind of really coordinating care for these special populations. And so, Leticia, I think I'd love for you to tell us more about those projects.
Right, it really is one area where I think they are ahead of the curve. So there is a registry of every single patient who requires this treatment and receives it frequently. And when and there's a network of facilities that provide this treatment. And so here in Florida, for example, when we knew that I lost count since I moved here, Ian and Helene and Milton and all of these hurricanes were coming. So there's an automated communication that goes out to the patient saying, this is coming early. Get your treatment, reschedule you for a little bit later in the day because we're scheduling everybody, but get a head start on this so you can, if everything shuts down, you won't be in a position that you need it immediately. Because it is a network, they all communicate. So the facilities that, as the facilities come back online, they start communicating with patients. You had this as many days ago, and so you're in priority to go to this facility, which is the closest one that just reopened near your house. And of course, they have the entire, before disaster strikes, moving in with the additional water and fuel and have that stored for once it passes, they can come back online very quickly. And one of my favorite things, of course, automated messages. We have electronic health records. Have you ever forgot to pay any medical bills? They will find you. But we're not, when it comes to letting patients know that this disaster is coming and you're, receiving chemotherapy, this might be, a good idea to do something. We're way behind. And another thing that I think that this network has been doing that it's a lesson that we could implement with cancer is that instead of saying to the patient, there is a hurricane coming, have a disaster plan, they would say, here is what you need to do. How many of these boxes have you checked? Also, we pre-register you for a special needs shelter. So, if you want to shelter in place, we can't force you to leave your house, but if you would like to go, there will be medical staff on site. There will be a generator. You will not lose power. And COPD, there is a similar strategy that is being implemented to pre-register patients to these shelters that it's called special needs shelters that provide additional care, and then also have more of this sanitary public health, distancing and masks available to people who are staying there. So I love this question because we don't need to reinvent the wheel. There are a lot of lessons that we can learn from some other areas that would be super relevant and helpful for cancer care.
Yeah, thank you so much. This is really helpful and insightful. And many of our discussion today were around we need more data. There are a lot to learn about the challenges faced either at patient level, healthcare system level, or healthcare provider level. So what are the key research gaps that must be addressed to understand the impact of flooding disaster on lung cancer care delivery and patient outcomes? And how can this research inform effective policy changes?
Well, I'll start with kind of a simple plea, which is that severe weather-related events there's not a single mold. They come in all sorts of different flavors, and I think we would want our preparedness efforts to get better at having preparedness for all sorts of different components depending on what might come, and you can't always predict what pieces of it are going to dominate. And I almost look at these as almost like a new disease that's popping up for us. Unfortunately, it's more common now. We know in the context of climate change. And so my plea is to treat these as case reports. And I think any institution that goes through a 3-day crisis should write up their experience. And I want to read those. I want to see what people did, what worked, what didn't work, what challenge they had that they didn't expect to see, what held up, what was resilient and what wasn't. And these don't have to be big treatises, but a short kind of debrief write-up is so helpful to add to the literature. And so, if we get, a dozen of these per event from a smattering of hospitals, we learn richly what, lots of different flavors and what works. And I think that would be very informative to our work. So I try to do that at our institutions during our various crises. We've had a couple of them over the years, and that's my plea to anyone involved to do that.
Yeah, sure. And Jenny?
I think maybe my only parting thought would be to really impact enduring change and kind of policy. It has to really be accepted by the community, and it has to be adapted to the community. And so I think making sure that the research that's being done and the solutions that are being put forward have community members and leaders kind of involved in that, because that is how it's going to really be supported in the longer term, which is, I think, often a problem with some of the interventions or solutions that get kind of put through. So that would be my last.
Yeah, thank you. Leticia, any final thoughts?
I was going to say, what can be measured can be changed, right? For us to be able to do better, we need to be measuring these things, reporting these things that Dr. Anesi was saying, integrating knowledge that's coming from the healthcare professional, from the emergency manager, from the community, right? And so we look at the volume of data that we collect on so many things. And Dr. Renee Salas has some very great publications about why is there not an ICD code for I being impacted by a disaster. There's ICD codes for I stepped on a rabbit or whatever, right? There's so many of them. How come we're not keeping track of this? We cannot solve this if we don't know that it's happened. So until we start, there are a few case reports, but until there is incentive for these to be published, because again, this priority thing, right? You're overwhelmed and then you have to write the case report. You might still be traumatic for you to write it. And then to collect that in a systematic way is really the best way that we can find the solutions here.
Yeah. Thank you so much. And Soumya, do we have like any other questions?
We actually don't have any questions yet, but we're
George,
Yes, please go ahead.
Can I add one add-on to Dr. Lund's comment? And at the risk of getting a tiny bit political, which I won't do anything crazy, I promise. But we, speaking as a scientific, referring to the scientific community, not any political circle, have clearly lost some trust with the public, at least in our country, in the United States. And I think at least some of that stems from taking a tone of telling people how they should live. And even if we, in our heart of hearts, think we're right on those points, we've lost ground there, and that's probably not going to be the solution. And despite our efforts, our emphasis, at least in academic community, on community engagement, I think that a recognition that a more effective message is, here are tools for you to make good decisions for you and your family. That's different than you should do this. And so as we craft these things, I feel like that maybe, I don't know definitively, but maybe a more effective way to start bringing people back to listening to us. And I think that's going to be important. That is as far as I will go. Thank you.
Thank you so much. I mean, we really do appreciate taking such a key important conversation forward. We really do appreciate you, Dr. Anesi, Dr. Lund, and Dr. Nogueira. Thank you so much for you to be spending your Friday afternoon with us, and this has been lovely. It looks like we are running out of time, but hopefully we will, if we have any questions later on, hopefully you're okay if we were to send you some questions if we end up getting some audience questions. But yeah, thank you so much. This was great.
Yeah,
Thank you.
Thank you to the hosts. Thank you, everyone. Thanks, ATS.
Bye-bye.
Bye-bye.
Folks.